So in this seminar, we are going to talk about acute coronary syndromes, part 1. One of the seminal moments in cardiac critical care was the discovery that transmural myocardial infarction was the result of an occlusive thrombus in a coronary artery. It led to the introduction of thrombolytic therapy in the mid-1980s, followed by the superseding technology of balloon angioplasty and stent placement. Advances in reperfusion therapy have improved outcomes and have contributed to 20% decline in the annual mortality rate from coronary disease for the past decade, meaning 2010 to 2020. So it is a significant improvement because we found the transmural myocardial infarction as a result of occlusive thrombus in a coronary artery. Introduction. I wanted to set the standard how the recommendations have been laid out by American Heart Association and American College of Cardiology. The recommendations are threefold: class 1 recommendation, class 2 further divided into 2A, 2B, and class 3 no benefit and harmful. The class 1 based on multiple high quality randomized control trials. That means the recommendation has a validity. Class 2, as I said, there are 2A and 2B. One is moderate, the benefit outweighs the risk. And 2B, those are all color coded. The benefit is better than risk, but still the benefit is a little bit above the risk. On the other hand, the class 3 recommendations, no benefit or harmful. These are all based on the quality of evidence, again divided into 3 categories: level A, level B, and level C. The level A is more than one high quality randomized control trial or meta-analysis of high quality randomized control trials, meaning if the recommendation is class 1 with level A evidence, that shows that high quality information has been provided. Level B again divides into BR and BNR. One is BR means from one or more randomized control trials, and NR means non-randomized trials, like well-designed non-randomized studies, observational studies, and registry studies, so on and so forth. So that is the meaning of BR and BNR. Level C, there are 2. One is based on the limited data, observational and registry studies, and meta-analysis of such studies. Level CEO means expert opinion. We do not have an evidence based on the studies, but it's an expert opinion. So these are all low quality evidence. So how do we evaluate and manage suspected acute coronary syndrome? These are all purely based on Circulation 2025, August of this year. April of this year. Acute myocardial infarction is a result of occlusive thrombus in one or more coronary arteries. The trigger for thrombus formation is the rupture of an atherosclerotic plaque. The plaque disruption happens because of inflammation. More notably, monoamine oxidase liberated from leukocytes that causes a rupture of atherosclerotic plaque. In addition, the shear forces of the blood can cause rupture, especially when you have hypertension. The ruptured plaques are typically located at the branch points in the coronary circulation. This would look like that. This is an atherosclerotic plaque. It gets ruptured here. That releases thrombogenic lipids. That causes platelet aggregation and occlusion of thrombus and fibrin strands. It can cause complete obstruction of coronary arteries, or it can cause partial obstruction. If you really look at it, the treatment modality also pointed towards platelet inhibition, anticoagulant, fibrinolytic. So this particular picture is valuable in understanding and also treating acute coronary syndromes. The same picture which was published in Circulation. So rupture of atherosclerotic plaque initiates thrombus formation, and atherosclerotic plaques typically present at the edges of the coronaries or the branching points of the coronaries. There are three clinical syndromes have been described. One, STEMI, meaning transmural infarction caused by complete occlusion of the infarct-related artery. So STEMI stands for ST elevation myocardial infarction. Second is non-STEMI, result of incomplete or partial occlusion of the infarct-related artery. So the ST segment has not elevated but associated with the myocardial infarction. Third group is called unstable angina. It's a result of repetitive on-off episodes of coronary occlusion. The non-STEMI and unstable angina are typically grouped together as non-STEMI elevation acute coronary syndrome, otherwise called NSTE ACS. So whenever we call NSTE ACS, it groups both non-STEMI and unstable angina. How does the electrocardiographic interpretation of STEMI and non-STEMI? Identifying STEMI and non-STEMI gives you an idea how quickly the patient needs to be transferred to PCI hospitals. PCI stands for percutaneous coronary intervention. It's not available in all the hospitals. In the United States, only 30% of the hospitals have PCI capability. So non-STEMI acute coronary syndrome, new or presumed new and usually dynamic horizontal downsloping ST segment depression more than 0.5 millimeter in more than 2 contiguous leads, and T wave inversion more than 1 millimeter in more than 2 contiguous leads with prominent R wave or RS ratio more than 1 or transient ST segment elevation. So non-STEMI, you will see ST segment depression, T wave inversion, and prominent R wave or RS ratio more than 1. Many patients with non-STEMI have either non-specific ST segment or T wave changes or normal leakages. Very important. When the symptoms suggestive of acute coronary syndrome, if the initial leakage is normal, that does not exclude the patient does not have acute coronary syndromes. We are going to talk about how to evaluate in a suspected acute coronary syndrome. Please stay with us. The absence of electrocardiographic evidence of ischemia does not exclude ACS. STEMI, new or presumed ST segment elevation of more than 1 millimeter in more than 2 anatomically contiguous leads. Measure the J point in all leads other than V2, V3, and more than 2 millimeter in men more than 40 years, more than 2.5 millimeter in men less than 40 years, and more than 1.5 millimeter in women regardless of age leads V2 to V3. So very important parameters to remember. The patients more than 40 years, it has to be more than 2 millimeter. In less than 40 years, more than 2.5 millimeter in men, but in women, more than 1.5 millimeter signifies significant change irrespective of the age. The posterior leads, especially V7 to V9, should be obtained in patients with suspected left circumflex occlusion, particularly in the setting of isolated ST segment depression more than 0.5 millimeter in leads V1 to V3. Pre-hospital assessment. These are the recommendations. The recommendation for pre-hospital assessment and management considerations for suspected acute coronary syndromes. The level of recommendation is 1, meaning it is strong. In patients with suspected ACS, 12 lead EKG should be acquired and interpreted within 10 minutes of first medical contact to identify patients with STEMI, meaning the EMS, the emergency medical services, when they approach a patient, they should get ability to get the EKG and interpret and communicate with the hospital right away within 10 minutes. The second recommendation is in patients with suspected acute coronary syndrome in which initial EKG is non-diagnostic of STEMI, serial EKGs to detect potential ischemic changes should be performed, especially when clinical suspicion of ACS is high or symptoms are persistent or the clinical condition deteriorates. It's automatically done within 10 minutes, the first EKG, and repeat the EKG subsequently, typically 10 minutes later, at least 2 more times to make sure there are no evolving EKG changes. The third recommendation is in patients with suspected STEMI, immediate emergency medical services transport to the PCI capable hospital for primary PCI is recommended as a triage strategy with an FMC, the first medical contact to the first device system goal of less than 90 minutes. The whole idea is to get the patient to the cath lab in 90 minutes. That means when the EMS, emergency medical services, see the patient, get the EKG, communicate with the PCI capable hospital and transport them to that hospital so that the team is ready as the patient rolls in. The fourth recommendation is in patient with suspected STEMI, early advance notification of receiving PCI capable hospital by EMS personnel and the activation of cardiac cath team is recommended to reduce the time to reperfusion. Again, emphasize that early identification, communication with the PCI capable hospital, and get the cardiac cath or balloon angioplasty done with the goal in 90 minutes. So acute coronary syndrome, as we talked about, major two categories are STEMI and non-STEMI. In STEMI, as you can see, the completely occlusive thrombus, which is evident in EKG as ST segment elevation. It needs to be in two contiguous leads. The troponin level might be there or might not be there, but the symptom will be there. Especially if the symptoms are shorter, the troponin levels may not have a time to rise. On the other hand, in non-STEMI patients, so partial occlusion of the thrombus, it causes ST segment depression and T wave inversion. Non-STEMI will have cardiac markers, meaning the sensitive troponin levels. In unstable angina, that may not be there either. There are 5 types of acute MI. The type 1, caused by acute coronary atherothrombosis, is usually precipitated by atherosclerotic plaque disruption. It could be rupture or erosion, and often associated with the partial or complete vessel occlusion. Type 2, caused by an imbalance between myocardial oxygen supply and demand unrelated to acute coronary atherothrombosis. Type 3, cardiac death with symptoms of myocardial ischemia and presumed ischemic electrocardiographic changes or ventricular arrhythmia before blood samples for cardiac biomarkers can be obtained or increase in cardiac biomarkers can be identified and or in whom myocardial infarction is identified by autopsy. That means EKG changes and troponin markers may be delayed, but the cardiac death happens because of myocardial ischemia. Type 4 is related to PCI. It's further divided into 3 categories. 4A, peri-PCI myocardial infarction caused by procedural complication and detected less than 48 hours after PCI. 4B, post-PCI MI caused by coronary stent or stent scaffold thrombosis. 4C, post-PCI MI caused by coronary stent restenosis. Type 5, peri-CABG is peri-CABG MI caused by procedural complication detected less than 48 hours after CABG surgery. So most common being the acute coronary atherothrombosis resulting in partial or complete vessel thrombosis. What do we need to do in hospital? These are all the recommendations by AHA and ACC. It's again class 1 recommendation based on non-randomized information. In patient with suspected ACS, acquisition and interpretation of an ECG within 10 minutes is recommended to help guide patient management. Second, in patient with suspected ACS in whom the initial EKG is non-diagnostic, serial 12-lead EKG should be performed to detect potential ischemic changes, especially when clinical suspicion of ACS is high, symptoms are persistent, or clinical condition deteriorates. Third, in patient with suspected ACS, cardiac troponin should be measured as soon as possible, preferably using high sensitivity cardiac troponin. Fourth, in patient with suspected ACS with an initial high sensitive troponin or cardiac troponin that is non-diagnostic, the recommended time interval for repeat measurements in case of high sensitivity cardiac troponin 1 to 2 hours, in the conventional cardiac troponin 3 to 6 hours. So it's preferable to do high sensitivity troponin because if it is negative, repeat after 2 hours or 1 hour, that should show elevation in case of myocardial ischemia. So in actuality, what happens when the patient gets there, if it is not already done, to only EKG and troponin done simultaneously. This is an algorithm. When the patient gets in history and physical examination, suspected acute coronary syndrome, EKG needs to be done and interpreted within 10 minutes and obtain cardiac troponins. Most notably, the high sensitive cardiac troponins need to be done. If it indicative of STEMI, evaluate for reperfusion therapy. If it is not STEMI, and do a serial EKG detect ischemia and a serial troponin. In case of high sensitivity troponin, repeat after 1 to 2 hours. In a conventional troponin, 3 to 6 hours. Then, the clinical decision pathway define the risk. In a low-risk patients, watch and possibly discharge home or keep them observation in the hospital for a short period of time. Intermediate, the same way, unless otherwise they progress to high risk. When they go to high risk, non-STEMI, then ongoing assessment for death or recurrent ischemia, or initiate medical therapy or assess for invasive evaluation. There are some risk stratification tools to assess acute coronary syndromes. One is GRACE risk score, a TIMI risk score for unstable angina or non-STEMI, and TIMI risk score for STEMI. The target outcomes for GRACE: in hospital 6 months, 1 year, 3 year death. So it has correlated. The variable used in GRACE risk score was in hospital, age, Philip class, systolic blood pressure, heart rate, ST segment elevation, cardiac arrest on admission, serum creatinine, and elevated cardiac biomarkers. TIMI risk score for unstable angina or non-STEMI, the variable used: age more than 65, more than 3 risk factors for coronary artery disease, known coronary stenosis more than 50%, ST segment deviation more than 0.5 millimeter, more than 2 anginal events prior 24 hours, aspirin use in prior 7 days, elevated cardio biomarkers, could be CKMB or troponin. Nowadays, predominantly we'll do the high sensitive troponin. And TIMI risk score for STEMI, age 65 to 74 or more than 75, 2 to 3 points, CLIP class 2 to 4, 2 points, systolic blood pressure less than 100, 3 points, heart rate more than 100 BPM, 2 points, anterior ST segment elevation or left bundle branch block, 1 point, diabetes, hypertension, angina, 1 point, weight less than 67 kilo, 1 point, time to treatment more than 4 hours, 1 point. So these are all not very well detailed in this particular document, but its reference have been given to CE 2021 guidelines. So recommendation for management of patients presenting with cardiac arrest. The first recommendation, patient with cardiac arrest and STEMI who have been resuscitated should be preferentially transferred by EMS to PPCI capable center. The second recommendation is the patient who have been resuscitated after cardiac arrest and are non-comatose who are comatose with favorable prognostic features with the evidence of STEMI should undergo PPCI to improve survival. Third recommendation, so 2B recommendation, in patients with cardiac arrest who are comatose have favorable prognostic features and evidence of STEMI, PPCI may be reasonable after individualized assessment. Even those who are comatose after a resuscitation with the evidence of STEMI, PPCI needs to be done. But on the other hand, the fourth recommendation differs in resuscitated patients who are comatose after cardiac arrest, electrically and hemodynamically stable, but without evidence of STEMI, there is no reason to put them into angiography. So when there is a suspicion of STEMI, these recommendations suggest send them to PPCI hospital to get PCI done. What are the standard medical therapy for STEMI? One is oxygen. It's kind of a little different from the previous recommendations. The first recommendation is in patient with acute coronary syndrome and confirmed hypoxia, meaning saturation less than 90%, supplemental oxygen to increase oxygen saturation to keep it more than 90% is recommended to improve myocardial oxygen supply and decrease anginal symptoms. When the oxygen saturation is more than 90, the routine administration of supplemental oxygen is not recommended because it does not improve cardiovascular outcomes. The reason they say is when there is no hypoxemia, giving oxygen causes coronary artery vasoconstriction, further compromises ischemia or further accentuates ischemia. Second is analgesia. Nitroglycerin sublingual, 0.3 or 0.4 milligram every 5 minutes is needed up to a total of 3 doses. Used in hemodynamically stable patient with a systolic blood pressure more than 90. Nitroglycerin IV start at 10 mics per minute and titrate to pain relief and hemodynamic tolerability. Consider for persistent anginal pain after oral nitrate therapy, or if the ACS is accompanied by hypertension or pulmonary edema, avoid use in suspected right ventricular infarction or systolic blood pressure less than 90 or change in systolic blood pressure more than 30 below baseline. Tachyphylaxis may occur after approximately 24 hours, so keep that in mind. Second, morphine IV, 2 to 4 milligram may repeat if needed every 5 to 15 minutes. Doses up to 10 milligram may be considered. Used for relief of pain that is resistant to other maximally tolerated anti-ischemic medications. Theoretically, it can delay the effects of oral P2Y12 therapy. It's monitored closely for adverse effects. So even though we delay the effects of oral P2Y12 therapy, it has not shown change in the clinical outcomes. Keep that in mind. Fentanyl IV, 25 to 50 microgram, may repeat if needed. Doses up to 100 microgram may be considered. Used for relief of pain that is resistant to other maximally tolerated anti-ischemic medications. May delay the effects of oral P2Y12 therapy. Monitor closely for adverse effects. Third is antiplatelet therapy. These are all the following recommendations. In patients with ACS, an initial oral loading dose of aspirin followed by daily low dose aspirin is recommended to reduce death and MACE. That means major adverse cardiovascular events. The major adverse cardiovascular events are myocardial infarction, stroke, cardiovascular death, other reperfusion procedures. The dosing consideration for oral antiplatelet therapy in patients with ACS. An aspirin for both STEMI and non-STEMI, loading dose 162 to 325 milligram orally. Aspirin, non-enteric coated, should be chewed when possible to achieve faster onset of platelet action. Loading dose should be administered for patients already on aspirin therapy. It's very important. Even if the patient is already on aspirin therapy, the loading dose needs to be given. The maintenance dose is 75 to 100 milligram orally daily. Again, non-enteric coated. The second one is clopidogrel for STEMI and non-STEMI without fibrinolytic pulse. Non-STEMI or STEMI without fibrinolytic. Loading dose is 300 or 600 milligram orally, maintenance 75 milligram orally daily. STEMI with fibrinolytic, loading dose is 300 milligram orally, so half the dose, if the age is less than 75. Initial dose is 75 milligram orally if age is more than 75. The maintenance is 75 milligram orally daily. So the age makes a difference of loading dose, and also with or without fibrinolytic in STEMI patients makes the difference because of the increased risk of bleeding. Prasugrel, non-STEMI ACS or STEMI without fibrinolytic and undergoing PCI. Loading dose 60 milligram orally, maintenance dose 10 milligram orally daily if body weight is more than 60 kilos and age less than 75 years. Maintenance doses decreases if body weight is less than 60 kilos or age is more than 75. Again, for the same reason, the bleeding. Ticagrelor, non-STEMI ACS or STEMI without fibrinolytic. Loading dose is 180 milligram orally, maintenance dose 90 milligram orally twice daily. So oral P2Y12 inhibitors during hospitalization. These are all the following recommendations. The level 1 recommendation, patient with ACS, an oral P2Y12 inhibitor should be administered in addition to aspirin to reduce major adverse cardiovascular events. The second recommendation is patient with history of stroke or transient ischemia attack. Prasugrel should not be administered because of worse net clinical outcomes. Again, it increases the chance of bleeding. So when there is a history of stroke or transient ischemia attack, the prasugrel should not be administered. So otherwise, in patient with the ACS, P2Y12 inhibitor should be administered in addition to aspirin that reduces major adverse cardiovascular events. The third recommendation is in patient with non-STEMI ACS undergoing PCI, prasugrel or ticagrelor is recommended to reduce MACE and stent thrombosis. It's recommended to give aspirin plus one of them. We are going to repeat that one in another slide. The fourth recommendation is in patient with non-STEMI ACS are managed without planned invasive evaluation, ticagrelor is recommended to reduce MACE. In the absence of invasive evaluation, the recommendation is ticagrelor along with the aspirin. Those who are undergoing PCI, you can choose prasugrel or ticagrelor to reduce the MACE and stent thrombosis. The fifth recommendation is in patient with non-STEMI ACS, clopidogrel is recommended when prasugrel or ticagrelor is not available, cannot be tolerated, or contraindicated. So if you don't have those medications, ticagrelor and prasugrel, clopidogrel can be used. But the first recommendation being prasugrel and ticagrelor. The sixth recommendation is in patients with non-STEMI ACS planned for an invasive strategy with timing of angiography and anticipated to be more than 24 hours, upstream treatment with clopidogrel or ticagrelor may be considered to reduce MACE. The seventh recommendation is patient with STEMI managed with PPCI. Prasugrel or ticagrelor should be administered to reduce MACE and stent thrombosis. So STEMI with PPCA also same, prasugrel, ticagrelor along with aspirin, similar to non-STEMI. In patients with STEMI managed with PPI, clopidogrel recommended to reduce MACE. When prasugrel and ticagrelor are unavailable, cannot be tolerated or contraindicated. So the first one is either prasugrel or ticagrelor. The ninth recommendation is in patients with STEMI managed with fibrinolytic therapy, clopidogrel should be administered concurrently to reduce death and MACE. So in patients with fibrinolytic therapy, the favored medication is clopidogrel. This is in picture. ACS initial selection of P2Y12 inhibitor. PCI non-STEMI ACS or STEMI. Recommendation, class 1 recommendation is aspirin plus ticagrelor or prasugrel. The clopidogrel used only if these medications are not available, not tolerated, or contraindicated. When the patient is undergoing CABG, the recommendation is aspirin with ticagrelor or clopidogrel. Again, class 1 recommendation. Continue aspirin during CABG and start inhibitor when safe postoperatively. When there is no planned invasive evaluation, the recommendation is aspirin with ticagrelor. Clopidogrel, when ticagrelor is not available, cannot be tolerated or contraindicated. STEMI with fibrinolysis. The recommendation is aspirin with clopidogrel. It's a class 1 recommendation. So a little bit change. So you need to be watchful. Alternate P2Y12 inhibitors can be considered at PCI if applicable. So management of oral P2Y12 inhibitors for patients who require CABG surgery. Clopidogrel. For elective CABG, interrupt for 5 days before surgery. When you need to do an urgent CABG, interruption for at least 24 hours ideally, and proceeding earlier than 5 days may be reasonable. Prasugrel, elective CABG interrupt for 7 days before surgery. Urgent CABG interruption for at least 24 hours and proceeding earlier than 7 days may be reasonable. Ticagrelor, elective CABG interrupt for 3 to 5 days. Urgent interruption for at least 24 hours and proceeding earlier than 5 days may be reasonable. So most of these P2Y12 inhibitors can interrupt for 3 to 7 days. If it is an elective, urgent, at least for 24 hours. Intravenous P2Y12 inhibition. The recommendation is 2B category. Among patients with the ACS undergoing PCI who have not received P2Y12 inhibitor, intravenous cangrelor may be reasonable to reduce peri-procedural ischemic events. The advantage of cangrelor, one is intravenous, meaning it acts immediately and the effect lasts for 1 to 2 hours after the cessation. In patients with the ACS, glycoprotein 2B and 3A inhibitors should not be administered routinely due to the lack of ischemic benefit and increased risk of bleeding. So it's harmful. So do not give glycoprotein 2B and 3A inhibitors. When to and how to transition from intravenous gangrelor infusion to oral P2Y12 inhibitors. Clopidogrel loading dose is 600 milligram. When to switch over immediately after discontinuation of gangrelor. Prasugrel 60 milligram loading dose immediately after discontinuation of gangrelor. Ticagrelor is a little bit different, 180 milligram loading dose at any time during or immediately after the discontinuation of gangrelor. Intravenous glycoprotein 2B and 3A inhibitors. This is all the recommendation. The recommendation is 2A. In patients with the ACS undergoing PCI with a large thrombus burden, no reflow or slow flow, or adjunctive use of an intravenous or intracoronary glycoprotein 2B and 3A inhibitor is reasonable to improve procedural success and reduce infarct size. Next category is anticoagulation, parenteral. The recommendations are as follows. In patients with non-STEMI ACS, intravenous heparin is useful to reduce ischemic events. In patients with non-STEMI ACS in whom an early invasive therapy approach is not anticipated, either enoxaparin or fondaparinux are recommended alternatives to heparin to reduce ischemic events. Again, the first preference goes to heparin, but if the invasive approach is not available, other options are enoxaparin and fondaparinux. Anticoagulant therapy in patients undergoing coronary revascularization. So the third recommendation in patients with ACS undergoing coronary revascularization could be CABG or PCI in the same admission. Parenteral anticoagulation should be continued until revascularization to reduce ischemic events. It needs to be continued throughout the hospital stay, I think the maximum of 8 days. The fourth recommendation is in patients with ACS undergoing let me take this off. In patients with the ACS undergoing PCI, intravenous heparin is useful to reduce ischemic events. The fifth recommendation is the STEMI undergoing PCI, bivalirudin is useful as an alternate heparin to reduce mortality and bleeding. So bivalirudin is alternate. The first go-to is heparin infusion. So you might ask, why do we use bivalirudin at all? Those patients who are sensitive to heparin or those patients who have heparin-induced thrombocytopenia, like HIT, those patients, definitely you need an alternative. One of the alternative is bivalirudin, so thrombin inhibitor. The 2B recommendation is in patients with non-STEMI ACS undergoing PCI, bivalirudin may be reasonable as an alternative to heparin to reduce bleeding. In patients with ACS, intravenous enoxaparin may be considered as an alternative to heparin at the time of PCA to reduce ischemic events. It's an interesting concept. I have seen some studies showing enoxaparin reduces the death rate, so on and so forth. But still the practice is heparin first and bivalirudin, enoxaparin are secondary. Those are all, as you can see, those are all 2B recommendations. Third, the harmful, this is very important. In patients with the ACS, fondaparinux should not be used to support PCI because of the risk of catheter-related thrombosis. So the idea we get is heparin, alternatives are bivalirudin and enoxaparin. Fondaparinux does not have any role. The ninth recommendation in patients with STEMI treated with fibrinolytic therapy, parenteral anticoagulation should be continued for the duration of the hospital stay, maximum of 8 days, or until revascularization is performed to reduce ischemic events. 10th recommendation in patients with STEMI treated with a fibrinolytic therapy who are not intended to undergo an invasive therapy. Enoxaparin is the recommended anticoagulant to reduce ischemic events. As you can see, the level of evidence is A. So the evidence is very solid. In patients with STEMI treated with fibrinolytic therapy who are not intended to undergo an invasive therapy, fondaparinux is recommended alternative to reduce ischemic events. So the very important thing is, if it is prolonged, enoxaparin and fondaparinux can be entertained. The only time is you cannot use fondaparinux when you have PCI with a stent in place. So the dosing of parenteral anticoagulant in acute coronary syndromes. Initial therapy loading dose with heparin, loading dose of 60 international units per kilogram, max of 4,000 international unit, with the initial infusion of 12 international units per kilogram per hour, max 1,000 units per hour, adjusted to therapeutic APTT, actuated PTT, range of 60 to 80 seconds. But in support of PCI, it's a different dosing. Please watch this one. In patients who have received prior anticoagulant therapy, additional heparin is needed to achieve ACT of activated clotting time, 250 to 300 seconds. In patients who have not received prior anticoagulant therapy, 70 to 100 unit per kilogram initial bolus to achieve the target of ACT of 250 to 300. With fibrinolytic therapy, the loading dose is lower, 60 international units per kilogram, maximum of 4,000, with the initial infusion of 12 international units per kilogram per hour, maximum 1,000 international units per hour, adjusted to APTT range. Bivalirudin to support PCI, 0.75 milligram per kilogram bolus, 1.75 milligram per kg per hour, IV infusion during PCI procedure. Post PCI infusion, 1.75 milligram per kg, the loading dose, 1.7 milligram per kg per hour for 2 to 4 hours post PCI. In patient with creatinine clearance less than 30, reduce the infusion to 1 milligram per kg per hour. Enoxaparin, initial therapy, 1 milligram per kg subcutaneous every 12 hours, reduce the dose to 1 milligram per kg per day if the creatinine clearance is less than 30 ml per minute. To support PCI for previous treatment with enoxaparin, if the last subcutaneous dose was administered 8 to 12 hours earlier, or if only one subcutaneous dose of enoxaparin has been administered. An IV dose of 0.3 milligram enoxaparin should be given. If the last dose was administered within the previous 8 hours, no additional enoxaparin should be given. For patients who have not received prior anticoagulant therapy, 0.5 to 0.75 milligram per kg IV bolus needs to be given. With fibrinolytic therapy, if the age is less than 75, 30 milligram IV bolus followed in 15 minutes by 1 milligram per kg subcutaneous every 12 hours, maximum of 100 milligram for the first 2 doses. If the age is more than 75, no bolus. 0.75 milligram per kg, the dose is also lower. Subcutaneous every 12 hours, maximum 75 milligram. The dose is again lower from 100 milligram to 75 milligram for the first 2 doses. Regardless of the age, if the creatinine clearance is less than 30 ml, 1 milligram per kg subcutaneous every 24 hours, not 12 hours. So keep that in mind. Fondaparinux initial therapy, 2.5 milligram subcutaneous daily, with fibrinolytic therapy, 2.5 milligram IV, then 2.5 milligram subcutaneous daily starting following day. Contraindicated if the creatinine clearance is less than 30 ml per minute. Fondaparinux should not be used to support PCI because of the risk of catheter-related thrombosis. Next is lipid management. The first recommendation is in patient with ACS, high-intensity statin therapy is recommended to reduce the risk of MASH. So we are going to talk about what is high intensity, medium intensity, and the low intensity lipid-lowering drugs. The second recommendation in patients with ACS who are already on maximally tolerated statin therapy with the low-density lipoprotein cholesterol, which is LDL-C, more than 70, adding a non-statin lipid-lowering agent is recommended to further reduce the risk of MASH. Third recommendation, in patients with the ACS who are statin intolerant, non-statin lipid-lowering therapy is recommended to lower LDL-C and reduce the risk of MASH. Fourth recommendation, which is 2A category, in patients with ACS who are already on maximally tolerated statin therapy with LDL-C 55 to 69, adding a non-statin lipid-lowering agent is reasonable to reduce the risk of MASH. Fifth is 2B recommendation. In patients with ACS, the concurrent initiation of STEMI in combination with maximally tolerated statin may be considered to reduce the risk of MASH. One other thing I want to throw in, when you are doing a statin therapy, when the patient comes with the ACS, I think starting with high-intensity statin therapy, if the patient is not already on high-intensity statin therapy, or adding non-statin, is recommended to reduce the LDL-C. There is no issue in bringing LDL-C very low. In fact, it's beneficial. So Based on the baseline lipid profile, the patient not on statin or on low or moderate intensity regimen, initiation of high intensity statin therapy is a class 1 recommendation, and reassess lipid profile 4 to 8 weeks after discharge and adjust therapy as needed to achieve desired lipid targets. One may even consider addition of STEMI-B. It's a class 2B recommendation. The patient already on a maximally tolerated statin regimen. This particular group, look at the LDC, the low density lipoprotein cholesterol, whether it is less than 55 or 55 to 69 or more than 70. If it is less than 55, continue the high intensity statin therapy, reassess lipid profile 4 to 8 weeks after discharge, and assess the dose to reach or achieve the desired lipid targets. When the LDL-C is 55 to 69, adding LDL lowering therapy is reasonable. It's a 2A recommendation. Again, follow up in 4 to 8 weeks. LDL-C, if it is more than 70, add a non-statin LDL lowering therapy. Again, class 1 recommendation. Again, reassess 4 to 8 weeks after discharge and adjust therapy as needed to achieve desired lipid targets. The patient statin intolerant or refusal. Some of the statins or people cannot tolerate statins. In those patients, add a non-statin LDL lowering therapy. So class 1 recommendations, repeat the lipid profile 4 to 8 weeks and adjust the dose to achieve the desired results. So what are the non-statin treatment options for lowering LDL cholesterol? STEMI-B. It blocks the Niemann-Pick C1L1 cholesterol absorption. It reduces LDL-C by 15 to 25%. One needs to watch liver function test abnormalities when you are using STEMI-B. Other two are monoclonal antibody, evolocumab, alirocumab. They are monoclonal antibody to PCSK9. Both reduces the LDL-C by 60%. Side effects are injection site reaction. Both of them reduces LDL-C and also decreases atherogenesis. Inclisiran, it inhibits PCSK9 synthesis, small interfering RNA. It reduces cholesterol by 50%. And the clinical trials and the ASVD are ongoing, but lots of people use inclisiran. And the side effects you will watch is injection site reaction. Finally, pempidoic oxide. It is ATP citrate lyase inhibitor. It reduces LDL-C 20%. It increases uric acid, thus you should watch for gout, gallstones, liver function abnormalities. The statin classification. What is high intensity? What is moderate intensity? What is low intensity? High intensity means atorvastatin 40 to 80 milligram or rosuvastatin 20 to 40 milligram. Moderate intensity, atorvastatin lower dose 10 to 20 milligram, rosuvastatin lower dose 5 to 10 milligram, simvastatin 20 to 40, pravastatin 40 to 80, rovastatin 40, fluvastatin XL 80, fluvastatin 40 milligram BAD, pitavastatin 1 to 4 milligram. In ACS patients, always go for high intensity therapy. There is no reason to hang on to moderate intensity or low intensity. The low intensity therapy, simvastatin 10, pravastatin 10 to 20, lovastatin 20, fluvastatin 20 to 40. Beta blocker therapy. The recommendation is in patient with acute coronary syndrome without contraindication yearly. That means less than 24 hours initiation of oral beta blocker therapy is recommended to reduce the risk of reinfarction and ventricular arrhythmias because it reduces heart rate, reduces myocardial oxygen consumption, and reduces ventricular arrhythmias, and thus it reduces ischemia and infarction. The second category is renin-angiotensin-aldosterone system. The recommendations are follows. In a high-risk patient with the ACS, meaning left ventricular ejection fraction less than 40%, Those with hypertension, diabetes mellitus, or STEMI with anterior location, oral AC inhibitor or an angiotensin receptor blocker is indicated to reduce all-cause death and MACE, especially when the patient is having either reduced ejection fraction, hypertension, diabetes. Adding the AC inhibitors at A or B is needed to be done. The second category is in patient with the ACS with left ventricular ejection fraction less than 40% and with heart failure symptoms and or diabetes. A mineralocorticoid receptor antagonist is indicated to reduce all-cause death and MACE. Another 2-year recommendation in patients with ACS who are not considered high risk, oral ACEI or on ARB is reasonable to reduce MACE. The reperfusion management for STEMI for the next week. I do not know whether it is going to be next week or next to next week, because there is another presenter is ready to do another topic next week, and we will see. Either it is going to be reperfusion talk or wound vac talk, if I'm remembering right, and we will let you know sooner. This concludes acute coronary syndromes part 1.